Well, why don't we go ahead and get started? We got a few folks on. So we have some kind of interesting cases here. They're not too challenging, but there's stuff that you kind of need to basically know. So who wants to give this one a go?
I can start. This looks like just like a ball of like a neoplasm that's proliferating in the dermis.
Yeah.
And it almost has this like, I don't know what the right word for the architecture is, but it's very blue.
Yeah.
That's just what I noticed on like high power. And it almost looks like tubular or branching at this power too.
Yeah, I agree. I think there you can tell. So probably it's going to be epithelial, right?
Yeah.
And here's the other part of it over here. You think it's benign or malignant?
It's super well circumscribed.
Yeah, exactly. If it's malignant, it's going to be like a metastasis or something unusual. So yeah, it's almost definitely going to be benign. So benign epithelial, and it's blue. So you're thinking maybe something basophilic. So we're going to higher magnification. You know, the nice thing about that is when you do that, you can sort of quickly say, well, you know, maybe it's going to be like in the follicular or basaloid category, or maybe it's going to be in adnexal neoplasm. So that's really the only, you know, you can maybe eventually get where you can make the definitive diagnosis of low power, but when you're kind of working through it, the low power stuff is good to kind of just get you sort of oriented. And then you go to higher magnification and see if there's any other features now that allow you to make a more specific definitive diagnosis.
Yeah, I think that some of these almost look like ductal or like you were saying adnexal of some sort.
Yeah, adnexal. And so it's basophilic, so epithelial adnexal. Mm-hmm. And, you know, of the basophilic epithelial, pretty much the two major ones are going to be things like things that are related to the follicle, or things that are maybe going to be related to the, you know, eccrine or apocrine gland. And then if you start seeing areas like this.
Yeah, that makes me more think glandular, like apocrine.
Yeah, good. Apocrine or eccrine, you know, so you know, again, I'm not a huge, you know, how many angels dance on the head of a pin kind of guy with regard to these. Basically, if you get into that category, I really don't care. I mean, guys argue whether this lesion is eccrine versus apocrine. I just think those arguments are kind of wasted. But basically, you can make the diagnosis of this specific entity. So you've got an adnexal neoplasm, ductal differentiation, glandular differentiation. Notice these two types of cells here. Can you see the color of these cells a little bit versus the color of these very peripheral cells here?
They almost look more like grayish or like.
Yeah, exactly. They're a little lighter. They're got a little sort of pallor to them, whereas the ones at the periphery are more round and cuboidal and a little bit more basophilic. So that also is a good clue to what kind of differentiation you may be looking at here.
I don't think it's like quite enough to be like cartilage, but I almost thought of like mixed tumor.
Yeah, this is mucin here. So when you get mucin that sticks around in the skin for a long period of time, and it actually, especially when it forms like a large sort of lake of mucin, it can then sometimes undergo cartilaginous metaplasia. So it's not really primarily cartilage. It actually turns into cartilage over the course of time. And so then basically it looks like chondroid in some areas. Let's look over here. Here it's really beginning to look like that. See right here? These are chondrocytes.
Oh yeah, those look more like.
So it's actually really formed cartilage there, but it starts off as mucin and then it eventually undergoes cartilaginous metaplasia. So you know what the diagnosis is, right?
Is it mixed tumor, like mixed chondroid syringoma?
Yeah, basically a mixed tumor of the skin. The other name for that is chondroid syringoma. And that is thought by most experts to be a lesion with eccrine differentiation. And if you see eccrine differentiation, where you get the small little glands without any obvious apocrine differentiation. You get the little cuboidal cells at the periphery, and then the clear cells. The clear cells are sort of recapitulating the cells in the sweat gland that undergo ionic, reabsorption. In other words, your sweat, when it gets excreted, is hypertonic, and then basically your cells down there that have the glycogen in their cytoplasm, like these cells, have an ATP mediated pathway there that reabsorbs the enzyme. So your sweat, actually, when it reaches the surface of your skin, is hypotonic, but it tastes salty because it still has some small amounts of ions in there, sodium and potassium and whatnot, and it dries and it gets concentrated on the outer part of your skin. But if you actually go in and look at the sweat itself, it's hypotonic. Sometimes they ask that on the board exam, interestingly enough. So this is a mixed tumor. Now there's one other lesion that can look very similar to this that's not in the skin. It's so-called pleomorphic adenoma, or mixed tumor of the mucosal surface. So you get a lesion in the salivary gland. It can look exactly like this. Looks just virtually identical to chondroid syringoma, or mixed tumor of the skin that's on glabrous skin. So just be aware of that. And those cells, those lesions also can sometimes have, actually almost always do have, myofibroblasts in there, and you can actually do a stain for a smooth muscle actin, and you can see that light up, usually kind of at the periphery, the little epithelial aggregations. So that one actually comes from the salivary gland, and this one's probably coming more from the eccrine glands, or differentiating towards that. So it's a nice example. And this is the kind of thing that the board examination is going to show you. They're not going to show you anything that's weird, that doesn't have any classic sort of morphology, and no controversies on the board. They want it to be pretty much straightforward. So just in contrast, this is another adnexal neoplasm. And notice that this one, this doesn't have really much mucin in it. If there's any mucin here, it's just kind of in the fibromucinous stroma that's surrounding the epithelial aggregations. And it's got some clear staining cells here also, and some basophilic cells as well. But this doesn't have it doesn't have a lot of ductal differentiation. It's got some over here, but it doesn't have the same number that we saw in the mixed tumor. It doesn't have the mucin, doesn't have the chondro differentiation. So this is an example of a nodular hidradenoma. And these are usually thought by most people to be apocrine in origin, but again, that's controversial. And a lot of these in the old days used to get called eccrine acrospiroma. People thought maybe they were eccrine because they had these little cells here, but sometimes you look at these and you'll see areas where there's obvious foci of apocrine differentiation. But that's just another example of an adnexal tumor. So I'd recommend knowing a little bit about the adnexal tumors. They're probably not going to ask you a ton of questions about it, but since they're pretty easy to diagnose, you may as well learn them and, basically get the, half a dozen or so questions they're going to ask you, so you can, bomb on some of the esoteric basic science questions that nobody ever knows the answers to. Okay. Anybody want to give this one a go?
I can discuss this one.
Good.
So we have a shaved biopsy of kind of a papillomatous appearing lesion.
Good.
Looks kind of crusted on scanning. And if you zoom in, it's like nicely well circumscribed. I kind of felt like it was probably a little benign growth.
Yeah, good. It's very small, isn't it?
Mm-hmm.
And obviously symmetrical and all those kind of things, and it's epithelial. And yeah, we'll go to higher magnification. And this is kind of where the action is, right?
Yes. And so it kind of looked like there was some acantholysis going on in the upper portion of the epidermis here. Or
really acantholysis?
Do you think like necrosis or like dyskeratosis? I don't know. I think some of them like dyskeratotic, like a little more like red and like pycnotic.
Yeah, I agree. There are some cells that are probably undergoing a type of dyskeratosis, or maybe sort of apoptosis in a way. There might be a couple of acantholytic cells here, but it's not the classic pattern of acantholytic dyskeratosis.
Okay. I was kind of like leading towards like an acantholytic acanthoma or something like that.
Okay.
I think the other like thought would be like a viral cytopathic change.
Notice if you look carefully inside the cells,
Mhm.
they kind of look like they're maybe dissolving a little bit. In other words, they're not really losing their adherence to one another, like you see in epidermolytic lesions or like an acantholytic lesion. Here you're seeing more like the cells themselves are kind of undergoing some kind of an unusual degeneration where there's also this pink granular material in the cytoplasm. And up here, you've got this sort of basophilic hypergranulosis, if you will. And then notice that there is all this parakeratosis overlying it here.
Yes, yeah.
So this is another reaction pattern. So focal acantholytic dyskeratosis is one of the epidermal reaction patterns.
Mm-hmm.
This is another one.
Okay.
You may not have seen this before, or you've probably heard of it, but notice how the cells seem like they're kind of undergoing a lytic change, if you will.
Huh.
And it's also getting
like
hyperkeratotic at the top.
Like an epidermolytic acanthoma?
Yeah, this is a so-called epidermolytic acanthoma. And the reaction pattern here is epidermolytic hyperkeratosis. Okay, so the concept of epidermal reaction patterns, basically the situation there is where the epidermis something happens to it for one reason or another, either some kind of genetic insult or maybe some kind of inflammatory insult or something like that. And then the epidermis reacts to that in a way. And so here, it's most likely some kind of a localized somatic mutation that's causing this abnormality. Because this is, and just fix this in your brain. This is epidermolytic hyperkeratosis. So they're gonna expect you to know that. And notice, just look at the morphology. The cells, the nuclei become kind of red.
Yeah.
And then as they get closer to the very upper part of the epidermis, and this is like a part of maybe a little follicle here, then they become hypergranulotic. They become purple. And then you get the sort of parakeratosis-like change overlying it here. And so you can imagine what this looked like clinically. So it's going to be kind of a scaly, crusted papule. And if you saw them clinically, they just almost look kind of like a wart or something like that. And so you sort of have to biopsy it to see what it's going to show. And then when you do biopsy it, it looks like this. So you said viral. There is one other reaction pattern that can look kind of similar to this, but generally it's relatively focal and it doesn't have the pink reddish color to the keratinocytes in the nuclei that you see here very commonly, like in a wart, for example. Coilocytic change can look kind of like epidermolytic hyperkeratosis, but it doesn't generally have these pink cells in it. It usually the cells just get kind of vacuolated. They get a little hyperkeratosis and hypergranulotic sort of basophilic change, but you don't usually get these little pink structures in the keratinocytes in a coilocytic change. Now, the other question that's important here is where do you see this reaction pattern? So this is what the board might ask you. So this is fair game. So they might look at this and they might say the best diagnosis in the solitary papule is, and they'll list epidermolytic acanthoma, which would be the right answer. But what might be a few other things they might throw in there as some, not quite as good answers, but they might show the same kind of epidermal reaction pattern.
Is it like epidermolytic ichthyosis or something? If it was like,
epidermolytic, the name so-called just epidermolytic hyperkeratosis, that's the kind of the old name that they used to use for that. Now they use non-bullous congenital ichthyosiform erythroderma. And when you biopsy that, it looks just like this. So if you just had a high power view of that, it can look the same. And they can get these really large papillomatous areas in there. I don't know if you've ever seen a patient with that yet, but they get these big, thick verrucous plaques, often on their They'd be widespread, and they get these areas that are kind of erythrodermic, and then they get these almost warty projections. They can be these huge spines. In fact, they used to call people that had that, porcupine man and things like that in the old days, because these things would form these large keratotic spines. And when you biopsy them, you see this prominent parakeratosis and this papillomatosis, and it shows the epidermal hyperkeratosis beneath it. So that's one setting where you can get it. What are a couple of other settings where you can get it?
I think you can see it in like a palmoplantar keratoderma.
Yeah, good. The so-called unithost type of keratoderma. You biopsy that, and it shows this kind of change. A lot of times those keratodermas, again, they can all kind of look similar clinically, and then you biopsy them, and you don't really know what the epidermal reaction pattern is going to be. So sometimes it's, just marked thickening of the cornified layer, like, somebody that's just got a palmoplantar keratoderma, something like they might have with PRP or psoriasis or something. Sometimes it looks like this. So it can look like a lot of different things. But there are a couple of other places where you can see it too.
I think the other one is like an epidermal nevus.
Yeah, good. Absolutely. Systematized epidermal nevus. And basically what's going on there is the same germline mutation that you get with epidermolytic hyperkeratosis, the widespread form. It just happens to hit a dermatomal area. So it's a post-zygotic mutation in that situation, but you biopsy it, it looks like this. I'd recommend knowing the mutation. I don't know it off the top of my head, but I would recommend that you know that, because that's where they might ask you to show you this and say the genetic mutation most commonly associated with this entity is, and that is an autosomal dominant disease, as I recall. So make sure you know that for the board examination. There's not too many other places that you can see the pattern. It's kind of interesting. You can get it sometimes in so-called disseminated epidermolytic acanthomas, and sometimes even patients that have Grover's disease, relatively recently reported. You can biopsy one of the lesions, and lo and behold, it'll have a little small focus of epidermolytic hyperkeratosis. It doesn't always have focal acantholytic disc keratosis or Haley-like change, or superficial pemphigus or pemphigus vulgaris-like change. So that's a nice example of this solitary epidermolytic keratosis, the other name for that, or epidermolytic acanthoma. And I'll show you this in contrast. So again, we talked about other reaction patterns. This is a lesion with a different reaction pattern. So who knows what reaction pattern we're looking at here?
Is this like acantholytic dyskeratosis?
Yes, good. This is
like a warty dyskeratoma?
Yes, exactly. This is warty dyskeratoma, and this is acantholytic dyskeratosis. And again, same concept. You get a lot of different diseases, about 5 or 6 different diseases where you can see this change in it, like Grover's disease, sometimes you can see it in Darier's, obviously, which is the classic example of it. You can get that in epidermal nevi also, post-zygotic mutation, same concept. So there's about 5 or 6 conditions where you can see this reaction pattern. So this is different. These are the chorones and grains and the acantholytic dyskeratosis. You can see how different this looks in the last one. So make sure you can look at these, tell what they look like, know the diseases associated with it, know the mutations associated with it, because that's you'll get those questions on the exam. If I were writing a board exam, I would definitely have some of those on there. Okay. Switch gears a little bit here. All right, who wants to give this one a go?
I can take this one. From scanning, the epidermis looks a little bit acanthotic, and then a little bit of, I think, what's parakeratosis, and then there's a large what looks like subcorneal pustule on the right side.
Good.
That's
we're doing an inflammatory process, right?
Mm-hmm.
And so you've already said several things. What's the inflammatory pattern in the dermis?
In the dermis, it kind of looks like superficial, somewhat perivascular.
Yeah, mostly superficial perivascular dermatitis, kind of goes to the mid reticular dermis, maybe a little bit deep, but it's not really nodular diffuse. It's not, no vasculitis, nothing like that. So kind of a superficial perivascular dermatitis with most of the change going on in the epidermis. I agree. And you also mentioned right away that you said there was an intraepidermal pustular dermatitis. So that's good. So once you get that, I mean, you've narrowed your differential diagnosis down dramatically. What's the differential diagnosis of this pattern?
So I think you definitely can think of like infectious things like impetigo. If you had like a really exuberant tinea, you can also think of, more like just inflammatory dermatoses, like drug reactions, like AGEP.
Good.
You could think of it's not like really psoriasiform, but you could think of like pustular psoriasis. I guess if it was like a really eruptive pustular psoriasis, you won't have like the classic psoriasis findings.
Good. No, those are exactly right. Those are exactly the things that you should think about. And so there's really not much need to go down any further esoteric differentials. So based on that, how are you going to distinguish between those entities, or among those entities, I guess I should say?
I think, part of it, I feel like you'd get kind of with history, like you'd want to know, like if it's something that if patients in the hospital, like super acute eruption, but, just looking at the path, you can also look at the cornified layer and see if you can, find any fungal elements or bacteria.
Did you see any fungal elements here?
I feel like I see what looks like maybe, I don't know if this looks like bacterial to me. Potentially it's a little like hyphae, but I kind of had a hard time seeing it.
Can you see these things here that I'm pointing out?
Yeah, are those like little spores?
Yeah, there's like a gazillion of them.
Oh, okay.
And notice where they're living. They really like to live in this sort of interface between the normal stratum corneum and then the abnormal sort of parakeratotic areas here where there's some crust, so-called sandwich sign. So that's where fungi like to live. And probably you can even see some over here too, right in this area. So they would probably show, this as high as the image can go here, they would probably give you a PAS stain, but there's so many of them here that you don't really even need a PAS stain. You can see that. Now, if these were bacteria, they would be smaller and they're going to be more basophilic. So notice that they're kind of oriented kind of horizontally, like they're kind of following the stratum corneum here. They're kind of orienting themselves almost like you can think of somebody just took peanut butter and spread it in this little sandwich area here. So they're kind of oriented along the parallel to the stratum corneum. And that's very common for dermatophytes to do that. They like to sort of live up there. They don't usually invade down into the epithelium. They're just basically sucking stuff out of the epidermis. And the neutrophils basically are induced because of the fungi actually, or obviously they don't normally live there. So depending on what kind of organism you're dealing with, you're going to get more inflammation if it's a zoophilic or geophilic organism, something like, T. Violatium, which lives in animals, or M. canis or something like that. They tend to be far more inflammatory than, say, T. rubrum, which tends to be more anthropophilic and doesn't give you quite as much inflammation usually, but it can. And so the good thing about this one is just to see how massive the infection can sometimes be. I mean, if you just look at a routine biopsy of tinea, you may only see like 2 or 3 hyphae in there. This has so many organisms. You kind of wonder if the person maybe even using topical steroids or something and just really allowed the organisms to proliferate dramatically. Because normally we don't see fungal infections that they're this florid, unless the person's immunocompromised or they've been using steroids or something like that on there. But your differential is exactly right. Those are the things you should look for when you see these neutrophils in the epidermis here. So that's good. And that's this example of tinea. Now, we have a contrasting biopsy here. This one comes from a different area. So notice there are no hair follicles here. And this came from a mucous membrane location. And it also has neutrophils up here. It doesn't have the same kind of dense collection of neutrophils that we saw in the last one, but we just have a lot of neutrophils in the superficial part of the epithelium. And if we look carefully here, you're going to see organisms. This probably would have been better maybe to get a PAS with this one, but there also are pseudohyphae that are kind of drilling down into the epithelium. Not seeing it as well with the picture right now, unfortunately, but it's in here. So maybe keep scrolling around to find it. But this is an example of candidiasis. And sometimes candidiasis will induce a really brisk pseudoepitheliomatous hyperplasia, like you see here, and it can simulate a neoplasm. And so I suspect in this case, they probably thought this was a cancer and biopsied it, and it had all this marked pseudoepitheliomatous hyperplasia. Yeah, I'm just not seeing a really good example of the organisms here for you. I wish we had a PAS of this, would have been better. But if you look at Candida, the organisms really, they live in the same area, but they actually are oriented at 90 degrees. So Candida likes to dig into the epithelium. So it actually is drilling for oil, whereas the dermatophytes usually just kind of live up in the cornified layer, and they don't usually, dermatophytes, as you know, don't really involve. That's probably a Candida organism right there. That's one right there. They don't really like the epithelium as much. They like the stratum corneum, whereas this thing likes the epithelium. Here's definitely one right there. Can you see that one? That's diving down. It's trying to go into the epithelium, and it's inducing all this inflammation, and it's inducing pseudoepitheliomatous hyperplasia. So if you ever get a patient that's got this, that's got all this verrucous hyperplasia, sometimes it can look pretty atypical, and it can actually simulate a cancer. So you want to make sure that you don't overcall this as cancer. If you diagnose this as a malignancy on somebody's lip, they're going to get Mohs. They're going to get like a big surgery, a wedge out of their lip. And if it's just an inflammatory infection, you don't want to do that. So the way to do that, if you see that, is to treat the Candida. Usually most of the pseudoepitheliomatous hyperplasia go away within about a month or 6 weeks. If it's still there at the end of it and you're still worried about a cancer, then take a biopsy after you've treated it adequately. But don't just call it a cancer if you're looking at something like this. It's got a lot of pseudocarcinomatous hyperplasia. So just remember the difference between Candida and Tinea. Tinea likes to live in a horizontally like this. Candida likes to go down this way. Candida, you won't usually see spores. You'll see the little yeast. Whereas in dermatophytes, you may see some chlamydospores up there. You may just see mostly hyphal elements. The fact that you're on mucous membranes more commonly in Candida versus a dermatophyte. Okay. This is a pretty easy one.
Well, I can do this one, but now I'm all nervous because you said it's easy.
That's subjective. Maybe it's hard for you, but
100% it's harder for me. So this looks like, I think it was a punch.
Yeah, absolutely a punch, a good punch. We guys an A for their punch.
So I feel like
squeeze it. See, a lot of guys, people take their punch, they take add some forceps and just squeeze it, and you'll see a little, kind of crush artifact there. We hate that.
So good job on the punch. And then I'm not seeing a whole lot of inflammation.
Yeah, good. I agree.
I'm wondering if there's some smooth muscle down there.
Yeah, there's some muscle here. Actually, is it?
Or striate, yeah.
Yeah, actually it's skeletal muscle, interestingly.
Skeletal. So that kind of makes me think about location. Not that really helped me, but it made me think about it. And then I'm seeing a lot of what I think are just sebaceous glands within the epidermis.
Good.
So, you know, they don't look particularly like odd to me. I'm seeing a little bit of like maybe acanthosis of the.
I agree. I think so. And it looks like it's probably been rubbed a little bit.
Yeah.
Like in simplex. Any idea what part of the body you're on?
Like maybe eyelid, or
it'd be pretty thick for eyelid. It's yeah, it's probably.
I don't know. I'm just thinking what's going to have muscle that close, unless it's. Are
these perfectly normal sebaceous glands?
I mean, it seems like a lot.
There are. Yeah, I agree. I think there's kind of a little bit too many. And it looks almost like some of the sebaceous cells are kind of almost in the epidermis a little bit.
Yeah.
Which is kind of abnormal.
Weird.
Now, certainly it's not a malignancy, right? We're not worried about cancer here at all. But it looks like there may be some kind of a malformation a little bit here.
Right.
And it might have been a little papule. And maybe they said, I don't like this papule. They kind of try to rub it or whatever. You know, whenever people get little bumps on their skin, they try to scratch them off. You know, the fingernail is the most common surgical instrument in the world. So they're trying to maybe remove it, or they rub it or whatever. So what's your differential diagnosis when you see kind of a lot of sebaceous glands per unit area like this?
Well, either if I'm thinking like neoplasm, I'll go to the
yeah, okay. You know, so it could be, you know, neoplastic or maybe hamartomatous.
Right.
Okay.
And so is that it? Like you can get like a like all the epidermal, or the, oh my gosh, what am I trying to say? Like a nevus, like one of the congenital nevi with like a nevus spacious. Or
yeah, nevus sebaceous. That would be one thing in the differential diagnosis. Does this look like a classic nevus sebaceous?
I didn't think so.
It looks a little different, doesn't it? I mean, usually nevus sebaceous will have the they have sebaceous lobules like this, but they'll also have other kind of marked verrucous hyperplasia. They might have overlying hamartomatous conditions like, you know, syringocystinoid papilliferum, or a basaloid hamartoma that looks like a basal cell, but it's not really that. And you'll often get sebaceous lobules that kind of empty directly into the epidermis. And this does look like there is some kind of a malformation here, though. I agree with you. It doesn't look like a classic nevus sebaceous, but it's certainly not just normal sebaceous glands that we see if we took a biopsy of somebody's face.
I mean, I'm hoping it's not just like a actual like sebaceous hyperplasia.
That's in the differential. It's a little bit funny because it's got some of this involvement of these annexals, follicles here. So you may not have heard of this, but what if I told you this was a little yellowish bump inside somebody's lip, right, the vermilion of their lip, and maybe a little bit of it on the inside of the mucosal side of their lip?
Is it like a?
That's probably the, you know, muscle of the, you know, one of the lip muscles, levator, or one of those things that the surgeons like to talk about.
Is this like one of those that has all the different names depending on like which mucosal surface it's on? What am I thinking of?
Yeah, probably so. A lot of guys sort of described these back in the old days. Yeah, so tell me what some of those names are, if you remember any of them.
Yeah, that's like so I'm trying to think of. It's early. Like a Fordyce, or
yeah,
like
Fordyce spot. Good.
Yeah,
that's what this actually turns out to be. And those are usually on the lip area. What do they call when they're on the areola? So it's not the areola because they don't have all the smooth muscle bundles that you'd see down there, the rectile tissue.
There's Fordyce. I think one of them starts with an M.
Yeah.
Like a, oh my gosh.
Montgomery's tuber.
Thank you. Yeah. Montgomery. Okay.
Yeah, you don't need to know all those names necessarily, but basically this is just an ectopic sebaceous glands. Nothing to worry about. It looks a little bit different than a nevus sebaceous. I guess I probably should have put a nevus sebaceous in here for comparison. We'll show you one of those down the road. But basically, this is just a benign proliferation of sebaceous lobules. So what they might do on a board examination is show you this, and they might say, okay, the differential diagnosis includes, and then list several things in the differential. And this might be one thing that they might put in there that I want to make sure you know what this is. So notice, see all the normal sebaceous glands over here. And then we've got this area over here where we've got these clear staining cells with a higher magnification and their obvious sebaceous differentiation, right?
Right.
Now, how come you said right? How come you agreed with me?
Because you're the boss and I agree with the boss.
You can disagree with the boss. That's perfectly fine. But you make sure you have a criteria for a sebaceous cell versus like a tricholemmal cell or like a clear cell of like an eccrine, gland like we saw earlier, right? So notice the nucleus looks like a little hyperchromatic star, and it's got these little gossamer strands of nucleoplasm that kind of radiate from it in this bubbly cytoplasm like this. So if you see that, that's how you can tell you're dealing with a sebaceous cell. So here's an early one. So this is going from a germinative sebaceous cell. It's growing into this one, to this, and finally to this. This is the last stage, because we know that sebaceous cells, they actually, when they secrete their, material, they die. They just dump everything in. It's whole liquid secretion. So this nucleus is dead. So it's getting ready to dump all the lipid into the lumen of the sebaceous gland. So that's kind of how that works. So is this a Fordyce spot here?
I don't think this looks weirder.
Absolutely no chance, right? This is not a Fordyce spot. Because we notice here, we've got all these primitive germinative cells. These are stem cells, basically, of the sebaceous gland. They formed a little benign tumor. And, these cells are got tons of DNA in there. They're rapidly proliferating. They're maturing into these sebaceous cells. And you'll often see mitotic figures in here as well. You don't see atypical mitoses. So this is another benign neoplasm of sebaceous differentiation. Does anybody know what this one would be called?
Is it a sebaceoma?
Yes, sebaceoma, which is basically sort of analogous to a trichoepithelioma of the follicular differentiation. And so when you see sebaceous cells and basaloid germinative cells, and more than 50% of them are germinative, by convention, we call that sebaceoma. If there's more than 50% of them that are the mature cells, and it's kind of got a cup-shaped architecture, it looks like a little sort of mini Ka, if you will, then we call it a sebaceous adenoma. And then there's some that sort of don't read the textbooks. They get called sebaceous epitheliomas or atypical sebaceous epitheliomas and things like that. But certainly it's a small benign lesion. It's not sebaceous carcinoma. We don't worry about that. But the one thing we do worry about here is the possibility of what?
Like
Muratory.
Yeah, they might have Muratory syndrome. So you want to make sure that they don't have that. So you can do some stains looking for microsatellite instability. That's one of the things we do to kind of screen for that. But this is a sebaceoma. The other one is another benign lesion of sebaceous differentiation, the Fordyce spot. Okay, and then there's the sebaceous adenoma, which is kind of in between those. Okay, great. All right, we got one more to do. Now, this one's important also, by the way, because the boards love to ask things like this. And they ask you, what's the, metabolic abnormality associated with this?
Fabry's, which I don't remember what
Yeah, Fabry's disease. Okay, so you jumped straight to the answer, which is good. You did. There actually are a couple of other diseases too that have been associated with these, but why Fabry's?
Because is this an angiokeratoma?
You tell me.
I think it's an angiokeratoma.
You tell me with absolute 100% certainty.
100% certainty this is an angiokeratoma.
Okay, good. Now tell me why.
Because I am seeing like the kind of thinner vessels with some, I'm like seeing the clotting, a little bit of increase, like the acanthosis of the epidermis.
Good.
There's a little
good, excellent. There's overlying acanthosis. It almost looks kind of like a verruca, doesn't it?
Mm-hmm.
Good, excellent. Notice where all the vessels are. Where are all these blood vessels?
In like the papillary.
Excellent. Papillary dermis. Usually, and that's where angiokeratomas really like to form. They're really involving the papillary dermis with the overlying verrucous epithelial hyperplasia, like you're seeing here, that you described quite nicely. So if you just look at the architecture, it kind of looks like a wart, but it's got all these blood vessels, and there's usually they have sludged erythrocytes in their lumen. There's maybe a little tiny bit of vascular, thrombosis up here. So good. This is an angiokeratoma, and yeah, this is what you can see with Fabry's disease. Now, there's several other scenarios where you can see angiokeratomas that are not associated with Fabry's. You know what those are too, right?
Normal people's skin.
Normal people's skin. You can just get a nasal ones that pop up every now and then.
Like other genetic stuff.
There's a couple of other genetic syndromes actually that can be associated with angiokeratomas.
I don't know off the top of my head.
Really, I think it's like a fumarate hydratase deficiency, I think was recently described. And I think it's also been associated with porokeratosis, which is interestingly enough there too. That was published just a couple of years ago. So, again, I'm not a geneticist, but I would recommend learning those because they love to ask those kind of things, and they expect you to be sort of up in the literature. I mean, you're taking the board. You're supposed to be the most up to date in all of dermatology because you're primed for the board. So they're going to expect you to know it. I'm pretty sure fumarate hydratase deficiency was the one. I know that. I'm pretty sure that was one associated with poro, but I think it may be associated with a variant of multiple angiokeratoma. So make sure you know those. And then you can see the so-called Mabelli type. You can see the type that usually occur like in the scrotal area and the labial area of older individuals. They look like caviar spots. But this is a classic angiokeratoma. So just if it looks kind of like a wart and it's got all these large ectatic blood vessels in the papillary dermis primarily, think of an angiokeratoma. Now, this is another vascular lesion. This is not an angiokeratoma. Notice where this one's located. This is deep, right? And we look at this higher magnification. What does this kind of look like? What does that remind you of? A thrombosis here. There's a lot of granulation tissue here. It's almost looks like it's sitting inside the lumen of a large blood vessel here. Anybody know what this diagnosis is? This looks like a pyogenic granuloma. If you just look at this in higher magnification.
Like a KS or angiosarc or?
No, this is very well circumscribed. It's inside a blood vessel. It's what we call intravascular papillary endothelial hyperplasia, or a tumor, Masson's tumor, which is, and that Masson actually described about 4 or 5 things, but this is basically analogous to intravascular pyogenic granuloma. So the blood vessel is usually like a large blood vessel that gets damaged or clots, and then a PG kind of develops inside the lumen of the blood vessel. It's totally benign, but notice how much different it looks than an angiokeratoma. So if they throw one of these vascular lesions on the exam and they put something like that in there for differential diagnosis, you're not gonna fall for that.
I was reading in Elston that like Masson's tumor most often occurs within the angiokeratoma. Like it can occur elsewhere. I don't know. Is that true?
We don't usually see Masson's inside an angiokeratoma. That pretty much be pretty unusual for that. Usually these are seen in larger blood vessels that kind of get, I think of it like somebody maybe gets a blood clot inside a blood vessel, and then it forms a nodule. And then you go in and biopsy it. Well, this is what it's going to look like. It's basically just kind of almost, it's really granulation tissue sitting inside the blood vessel. It's almost like an organized thrombus is really what it is. So you can see this thing's thrombosed, and probably it was due to trauma. Now you can sometimes see this occurring inside of an angioma, like maybe a large cavernous angioma that gets traumatized and then it clots, and then you get secondary granulation tissue that forms in it, but not generally in an angiokeratoma because those are too small to actually ever form that sort of granulation tissue-like reaction that we see here. Any questions?
Wait, yeah, I have a question. So is Masson's, what is like the name of it? The like formal name?
Intravascular papillary endothelial hyperplasia, which is a pretty good name when you think about it, because it's in the blood vessel, intravascular. It is papillary like this. You can see those kind of, papillary-like projections, if you will. Intrapapillary vascular endothelial cells hyperplasia. So it's basically like granulation tissue. So it's sort of a descriptive name that, people sort of took it away from Masson, but a lot of people still call it a Masson's tumor. Just think of it as an intravascular pyogenic granuloma is the best way to think about it. And it's sort of in the family of lobular capillary proliferations, which includes this pyogenic granuloma. Bacillary angiomatosis is a lobular capillary proliferation. Bartonellosis, verruga peroneana, lesions of that's also yet another one. So there are entities where you get this sort of lobular capillary proliferation. They all sort of look similar to this. Same sort of end stage reaction, usually due to some kind of stimulus. This one due more to trauma with clotting in the blood vessels, if you will.
Thanks.
You're welcome. Well, you guys have a great holiday, and we'll see you in the new year. Hopefully we'll be able to get back together face-to-face sometime in the next couple of years.
Thank you.
Thanks.
You're welcome. Take care.